Okay, it's taking a while, so just let's wait. Okay, we're all set. Okay, when we look at RBCs, we started with erythropoiesis. What's the site of erythropoiesis? Where are the RBCs produced?
Bone marrow.
Bone marrow. And what's the stimulus for this production of RBCs? What stimulates the stem cells?
Erythropoietin.
Erythropoietin secreted from the kidney. And what's the stimulus for release of erythropoietin by the kidney?
Low blood flow. Oh.
Hypoxia. Blood flow is related to blood pressure. So low blood flow will release renin because it can correct blood pressure. RBCs are associated with hemoglobin and oxygen, right? So low oxygen will stimulate release of erythropoietin. And once the bone marrow is stimulated, the stem cells get stimulated, and that leads to differentiation or maturation of the cells. So during each successive division, what's the main thing you notice here? What happens to the cell size?
Decreases.
It's decreasing. Finally, you get the mature red blood cell. What's the immediate precursor of the red blood cell?
Reticulocytes.
Reticulocytes. And you identify reticulocytes by bluish strand-like material. That's the remnants of the basophilic cytoplasm. So you see this bluish strands, that's the reticulocytes. Now in which condition the most of the times majority of reticulocytes get converted to RBC in you and me, right? So our reticulocyte count is less than 2%. In which condition will the reticulocyte count increase?
In life anemia or acute blood loss. Hemolysis.
Okay.
Hemolysis.
Yes, when the body is trying to make more. So when the body tries to make more red blood cells to compensate for the loss. So what I meant to ask is, for some reason the RBCs are not staying in circulation. That is hemolysis, hemolytic anemias. Since your RBCs are getting lysed, there's lack of oxygen, and that will stimulate erythropoietin, and that will cause accelerated erythropoiesis. And in that process, the reticulocyte count will increase. So in hemolytic anemias, reticulocyte count will increase. B12 and folic acid, they're required for cell maturation. Why? What's the role of B12 and folic acid? They synthesize what?
DNA precursors.
Purine, pyrimidine, methionine, etc. So these are the DNA building blocks. So that's why it's required for cell maturation. So any condition we don't have B12 folic acid, the maturation process gets arrested. So on the peripheral smear, what you see are the precursor cells. That's why it's called as megaloblastic anemias. What's the shape of red blood cell?
Biconcave.
Biconcave. And what are the proteins which maintain the biconcavity?
Spectrin. Anchoring. And 3.1.
Spectrin.
Anchoring, spectrin, and band 3.
And band 3, correct. So we have band 3 and spectrin attached with the help of ankyrin, and during which it gives rise to the biconcavity. Which is the disease where spectrin is defective?
Hereditary spherocytosis.
Hereditary spherocytosis. So for any reason, if spectrin is defective, the RBC loses its biconcavity and becomes spherical. What is sickle cell anemia? Because I told hemolytic anemias, I'm talking about the different causes of hemolysis. One is hereditary spherocytosis, and then I'm asking you about sickle cell anemia. What's the defect? Where is the defect?
Mutation. Beta chain of hemoglobin.
Beta chain of hemoglobin, and what's the defect? Which amino acid is replaced?
Glutamic acid. The glutamic acid gets replaced by valine at position 6.
Correct. Glutamic acid gets replaced by valine in the 6th position of the beta polypeptide chain. And during this replacement, fibrous strands are formed between the membranes, and this fibrous strand will retract one surface of the membrane, and that's why the cell assumes a sickle shape, and the hemoglobin is called as hemoglobin S. And the problem with sickle cells are they cannot flow freely in circulation. They clump together, affecting circulation. And if there is stasis of blood, what can it predispose to? clot formation. So these are the different causes for hemolysis. Plus, we also had another cause. What's the significance of G6PD?
Protects RBCs from oxidative damage.
Correct. It converts
NADP, NAD plus NADPH.
NADPH, and NADPH minimizes the production of oxidative stressors like hydrogen peroxide, etc., and protects the RBC membrane, maintains the biconcavity, etc. If there is G6PD deficiency, NADPH cannot be generated. There is oxidative damage to the cells, which can lead to hemolysis. So these are the different causes for hemolytic anemias. And what is another test we do? We measure the osmotic fragility. Okay, so when has the cell tendency to rupture? When it's placed in what type of saline solution? When will it rupture?
Hypotonic solution.
Hypotonic. Correct. So when RBCs are suspended in hypotonic solution, because of water entering, they can easily lyse. But in you and me, it won't lyse very easily. But what will happen in all these hemolytic anemias? Hereditary spherocytosis, sickle cell anemia, G6PD deficiency, the osmotic fragility will, cell is fragile. So what should happen to the osmotic fragility? Increase. So in the question, if you see osmotic fragility increase, that means the cell is easily lysed. Okay. Next, based on this, if erythropoietin secretion has increased and RBC count has increased, what do you call it as?
Polycythemia.
What type?
Primary polycythemia.
It's not primary. We call it as polycythemia. Secondary polycythemia, where only RBC count has increased. Somebody told primary polycythemia. If it is primary polycythemia, it's also called as, what's the other name for it?
Polycythemia vera.
Good. Polycythemia vera. So in primary polycythemia, the bone marrow is hyperplastic. There's bone marrow hyperplasia. So along with RBC, what will happen to WBC and platelets?
They all will increase together.
They all will increase. Whereas what did I tell you? Only RBC is increasing. So if only RBC is increasing, it has to be a erythropoietin excess. That's why only RBC is increasing. So what are the possible causes which can cause only erythropoietin excess?
Hypoxia.
Any condition of hypoxia. Good. And what are the diseases which can cause hypoxia?
COPD.
Any respiratory disease. Good. COPD. Or physiologically, where do we see hypoxia?
In the tumors, if you have a
Physiology.
high altitude.
High altitude, physiologically. And yes, I got what you were trying to say. If any tumor secreting erythropoietin. So the tumor could be in the kidney, or what's the other site where 15% erythropoietin gets secreted?
The lungs.
Liver.
Liver.
Okay, so any tumor of the liver, kidney can cause erythropoietin hypersecretion. High altitude and respiratory diseases because of hypoxia can cause increase in RBC count. And a primary polycythemia is otherwise called as polycythemia vera, where only the bone marrow is hyperactive, and because of that all the cells will increase. And due to a negative feedback mechanism, what will happen to the renal secretion of erythropoietin here?
It will be suppressed, decreased.
Correct. Because of a negative feedback, what will happen to the erythropoietin secretion actually in this primary polycythemia? It's actually going to be less. So did you get this? If erythropoietin is high and RBC count also is high, that means it's an erythropoietin dependent increase in RBC count. But if you see the RBC count high, along with that you see all the WBC platelet also high, but erythropoietin levels are later decreasing, that tells you that it was not erythropoietin dependent. Since it involved all the cells, it was a primary hyperactivity of bone marrow, which is nothing but polycythemia vera. Did you get this?
Yes.
Okay. So that is absolute polycythemia. What is relative polycythemia?
We have a
Normal RBC, but you have dehydration and just a lot.
So RBC count did not increase, but RBCs got concentrated. Okay? And why did RBCs got concentrated? Because of loss of fluid. right? So what is relative polycythemia? The RBC production was not the problem. RBC was produced normally, but due to loss of fluid, when you measured the hematocrit value, RBCs were concentrated, so hematocrit value increased. That's why we define polycythemia depending on the hematocrit. It's an increase in hematocrit, we say, okay? Because RBC count may not always increase. So give me some causes for only loss of fluid, concentrating your red blood cells.
Dehydration.
Good.
Burns.
Dehydration, burns due to loss of plasma. What else?
Excessive, what do you call the diarrhea.
Pardon me?
Vomiting, diarrhea.
Vomiting, diarrhea. So in the first block we did no body fluids. Diarrhea can lead to concentration of red blood cells. Diuresis, anything. Wherever only lots of fluid is lost, the RBCs will get concentrated. Good. Next, when we describe anemias, what is anemia? Decrease in
Red blood cell.
RBC count. What will happen to hemoglobin levels?
Decrease.
Decreased. Oxygen carrying capacity?
Decrease.
Decreased. Oxygen binding to 1 gram of hemoglobin?
Normal.
Normal, because 1 gram binds to 1.34 ml of oxygen. So which condition can affect the 1 gram binding capacity if all the 4 sites are not available? So in anemia, you have all the 4 sites available. So the 1 gram capacity remains normal. Give me a condition where the 1 gram capacity was less because only 3 sites were available for oxygen.
Carbon monoxide poisoning.
So in carbon monoxide poisoning, yes. The 1 gram capacity also, oxygen binding to 1 gram of hemoglobin is also going to be less. Okay, but in anemia, the 1 gram capacity is okay, but because the total hemoglobin decreased, oxygen carrying capacity decreased. Yes, Janai?
Sorry, just to clarify, so when you were talking about the primary and secondary polycythemia, those two are absolute, whereas the fluid loss one is relative.
Correct.
Cool, thank you.
Because absolute means it's absolutely increased. Absolute means there's an absolute increase in RBC count. Relative means the RBC production as such is normal, count is normal, but the cells have got concentrated. Why did they get concentrated? Because of loss of fluid. Okay?
Yeah, thank you.
Okay. Now we were talking about anemias. So in anemia, hemoglobin is less, oxygen carrying capacity is less, oxygen binding to 1 gram of hemoglobin is normal. Will they have hypoxia?
Yes.
Yes. Will the tissues get enough oxygen? No. So will there be
No.
hypoxia? Yes. But will there be hypoxemia? Hypoxemia means decrease in partial pressure of oxygen, and that is dependent on which form of oxygen?
Dissolve.
Dissolved. So in anemia, the dissolved oxygen, is it affected?
No.
No.
Dissolved oxygen remains normal. So partial pressure of oxygen remains normal. So there will not be hypoxemia. There is no hypoxemia, but hypoxia will be present. And for dissolved to be less, the dissolved oxygen is say 1.5%. So if you have the dissolved oxygen to be less, what is the criteria requirement? The diffusion itself should have been less. So if diffusion itself is less, then it will affect both the bound and the dissolved form. But in anemia, carbon monoxide and cyanide poisoning, the diffusion is okay. And as long as diffusion is okay, something happened with hemoglobin or after that, only the bound form is going to be less, whereas the dissolved oxygen is going to be normal. So these individuals will not have hypoxemia, but they'll only have hypoxia. Next, we classified the anemias where there could be loss of red blood cells, usually seen during hemorrhage, hemolysis, and you already told me in hemolytic anemias, the reticulocyte count will increase. What is aplastic anemia?
For the 1 meal when all cells decrease.
Bone marrow is aplastic.
Therapeutic drugs.
Therapeutic drugs, chemotherapeutic agents, radiation, etc. will suppress the bone marrow. So RBC, WBC and platelets. So if you see all the cells decreasing, it has to be aplastic anemia. And then we went on to discuss nutritional anemias. Under that, we discussed iron deficiency, B12, folic acid. So let's discuss this one by one. Tell me about iron deficiency. What increases solubility of iron?
Vitamin C.
Vitamin C. So if there is vitamin C deficiency, iron absorption will be decreased. Okay. Plus, who is prone for iron deficiency if the demand is more? So give me some physiological conditions where the demand increases. Pregnancy, lactation. Okay. So these are some of the physiological conditions where the demand is high. So if the mother does not take enough, she will have iron deficiency. So if the iron is there, iron is less, iron is required for the structural integrity of heme. Iron deficiency will collapse this heme structure. So the cell what you get is big or small?
Small.
You get small cells. Therefore, what are the blood indices we use? MCV, MCH, MCHC. What's the definition of MCV?
Volume of one RBC.
Good. Volume of single red blood cell. MCH is hemoglobin in single red blood cell. And MCHC is the percentage of hemoglobin in the entire hematocrit. Normal MCV value is
87.
87 femtoliter or cubic microns. MCH will be
29.
29
29.
picograms and MCHC is 34%. For my exam, I'll give you the normal values, don't worry. But if at all shelf or step they don't give, just remember the normal value. So in iron deficiency, give me the peripheral smear picture. That means what happens to MCV, MCH, MCHC?
Microcytic MCV decreases,
MCV
and then
decreases.
pH decreases, and the MCHC decreases.
Good. Cell is small. Small cell holds less hemoglobin and percentage also is less. So we call it as microcytic hypochromic anemia. And how will you treat it?
Give iron.
Iron supplements. You can also give vitamin C to enhance the absorption. That's about iron deficiency. Next, if MCV is increased, MCH is increased, what does that tell you? Cell is big or small?
Big.
Big.
Big. That means on the peripheral smear, we are seeing the precursors or the megaloblasts. So if you see this picture, where MCV has increased, MCH increases, but what happens to MCHC?
It stays normal.
The hemoglobin in each cell has increased, and because the cells are bigger, even though they are less in number, the average hematocrit is also on the higher side. They cancel each other, which gets the MCHC back to normal. So we call this peripheral smear diagnosis as macrocytic. Even though MCH is a bit high, ultimately the percentage is normal. So we still call it as normochromic. What are the differential diagnoses? Where do you find macrocytic normochromic? What are B12 deficiency, folic acid deficiency. What is the main or what are the other factors which can induce B12 deficiency?
Intrinsic factor deficiency.
Intrinsic factor deficiency. What do you call that as?
Pernicious anemia.
Pernicious anemia. Where is the site of absorption?
Terminal ileum.
Ileum. So in a person who has undergone terminal ileectomy because of a tumor or anything, that can also give rise to B12 deficiency. So in pernicious anemia, where is the problem? Why was intrinsic factor less? Where was the problem?
Parietal cells.
So in other words, I'm asking you, where is intrinsic factor secreted from? The
Parietal
parietal cells. Stomach.
Parietal cell.
Correct. So pernicious anemia, the cause could be defect in parietal cell. That means the problem is in the stomach. Ileectomy, of course, I would have to give you that patient had a surgery on the intestine or something. So that will relate to ileectomy. So what's the function of intrinsic factor? Why does it lead to B12 deficiency?
It carries the B12 to the primary ileum so it can be absorbed.
It is required for B12 absorption. So it cannot be absorbed. That's all causes for B12. So if it is a dietary deficiency, which diet can give rise to deficiency of B12?
Vegan diet?
Vegetarians.
Vegetarians.
Correct. Because it's found in meat. So a vegetarian diet can give rise to deficiency. Folic acid is richly found in vegetables. So a person who does not eat vegetables can have folic acid deficiency. So look for these clues. Plus, which other clinical symptom helps you to differentiate between B12 and folic acid?
Neurological symptoms?
Neurological symptoms. So if your patient has neurological symptoms, that means B12 is not working due to the fact that B12 helps in myelination. So if there's no myelin sheath, then neurological problems, it can lead to sensory and motor disturbance. So dietary deficiency of B12, how do you treat?
You treat with oral B12.
You give oral B12. Good. Pernicious anemia and terminal ilectomy patients, how will you treat B12 deficiency?
Injection of B12.
Injection, intramuscular injection.
Good. Intramuscular injections of B12. And folic acid, of course, you give folic acid supplements. So in order to monitor your patients, if they have B12 folic acid deficiency, when they come to you, what will happen to their reticulocyte count?
Decreases.
It has not reached reticulocyte, so it will be less. Following successful treatment, what should happen to the reticulocyte count?
Should increase.
Should increase. So if your treatment is working, the reticulocyte count should increase. So that should tell you that you're doing good. So that's about the different types of anemias and the peripherals in your picture in the different types of anemias.
Raja?
Yes?
Hypersegmented neutrophils that you will see in iron deficiency, right?
No, you tell me. Hypersegmented neutrophil indicates immature forms of neutrophils. So in which deficiency the cell is immature or arrested in the precursor stages?
B12 and folate deficiency.
B12. So predominantly in B12 deficiency, along with RBC maturation getting affected, WBCs also will be affected. So hypersegmented neutrophils again would be a sign accompanied in B12 deficiency.
Got it.
Iron has nothing to do with actually the maturation process, right? It's B12 and folic acid.
Is it just restricted to B12 or is folate as well as that question?
It could be in both actually because both are helping in the cell maturation process.
Okay, thank you.
Okay. So that's about B12 and folic acid deficiency and the different types of anemias. So if there is a renal failure, then why is there anemia? Justify this.
Less EPO.
Because they have less EPO. Good. So chronic renal failure can give rise to anemia. With that, let's move on to hemostasis. Following injury, what happens first?
Vasoconstriction.
Vasoconstriction.
You want to minimize blood loss, so vasoconstriction. Give me the mediators. What do the endothelial cells release?
In 2001?
Endothelin and serotonin.
Serotonin.
They cause vasoconstriction. Once the vessel has constricted, someone has to drag the platelets. Who's going to drag them?
The von Willebrand factor.
The endothelial cell releases von Willebrand factor. What's the other name for von Willebrand factor?
Factor 8.
Factor 8 antigen bound.
Good. Factor 8 antigen because it acts as a cofactor for factor 8 and helps in survival of factor 8. Which protein on platelets is von Willebrand attracted to?
GP1B.
Glycoprotein 1b. So that's why it starts attracting platelets. And what's that step called as?
Adhesion.
Good. Platelet adhesion. So once the platelets go to that site, they get activated. And during this activation process, what do they release?
Thromboxane and ADP.
Thromboxane A2, ADP, etc. And because of thromboxane A2, which glycoproteins on the platelets will interact with their receptors and form a complex with fibrinogen?
2B and 3A.
Glycoprotein 2B and glycoprotein 3A. So because of the formation of this complex, the platelets are dragged to each other, and in that process, the platelets will stick to each other. And the sticking of platelet is called as the platelet what?
Aggregation.
Aggregation. Following platelet aggregation, a compact plug is formed which goes and seals that vessel, and that gives rise to temporary platelet plug formation. What's the time interval from injury to temporary platelet plug formation called?
Bleeding time.
Bleeding time. Meanwhile, yes, Chennai?
Sorry, I feel I've asked you this before. So you know when the GPTB and 3A join, is that still platelet activation or is that then platelet aggregation?
No, platelet activation has to release granules which will release thromboxane A2.
And the joining of that is that aggregation?
That is dependent on thromboxane A2. So thromboxane A2 has to happen first, and only then they can come close to each other. Because it is thromboxane A2 which causes these glycoproteins to interact. So platelet activation.
Is that whole step called activation or is that aggregation?
Platelets are sticking together, they are aggregating. Activation means the platelet becomes irregular in shape and it releases thromboxane A2. So release of thromboxane A2 is called activation.
Okay.
And once thromboxane A2 is released, it will give rise to aggregation.
Okay, thank you.
And this aggregate will go and block the vessel. So that's called as temporary platelet plug. Meanwhile, the intrinsic and extrinsic mechanism have already started. But because they take a longer time, your temporary plug is already formed. So give me the pathway for intrinsic. What initiates the intrinsic pathway? What tells the intrinsic pathway to get activated?
The exposure to a rough surface.
A rough surface or electronegative surface. Rough surface means an injured surface. Electronegative, one example would be glass. Certain mediators are released, kininogen, kallikrein, etc. You don't have to actually remember too much about it, but I'm interested to know which is the first factor to be activated.
Hegemon factor.
12A, which is otherwise called as hegemon factor. That will activate several others and it will converge on which number, which is the common factor begin from?
10.
10. Meanwhile, extrinsic, what initiates extrinsic? What type of injury?
Tissue injury.
Tissue or endothelial cell damage.
Endothelial is mainly blood vessel you're talking about, right? Tissue or cell damage, cell membrane damage. Why? Because which factor is released first when there's tissue injury or cell injury?
3.
Factor 3 gets released. The other name for it would be
Tissue
thromboplastin.
tissue thromboplastin. So this tissue thromboplastin is found on the cell membrane. So for it to get released, the cell membrane has to rupture. That's why tissue or cell injury will rupture the membrane, which causes release of, otherwise how does 3 know when it has to release? So mainly it is tissue or cell injury, okay? And 3 will activate which factor?
7.
7, and that will activate 10. So for extrinsic you only have 3 and 7, and for intrinsic start from 12 and go in a descending order. So what comes before 12? Guys?
11.
11. 10 is common, so exclude 10. Then it will be
9.
9. 8.
Then 8.
Good. Factor 10 will then activate what?
Factor 5.
Okay, 5, calcium, etc. is used. And finally, what does it activate?
Factor 2.
Prothrombin to thrombin. Next, thrombin, what will it activate?
13.
No, before 13, fibrinogen has to get converted to fibrin, which is initially unstable. So as you mentioned, factor 13 gets activated. What's the other name for 13?
Fibrin stabilizing factor.
Fibrin stabilizing factor. So that will form covalent bonds, which converts unstable fibrin to stable fibrin. So this forms a good, strong meshwork, and this meshwork gets deposited on the temporary plug. And now the temporary plug is now called as the definitive clot.
Dr. Prakash, I have a question.
Yes?
Is factor 13 is it a direct factor of the common pathway?
Yeah, it acts independently because for the formation, clot by definition is formation of fibrin. So even when one fibrin strand is formed, we conclude that the clot has formed, right, when we did that test. Okay? So the factor 13, what is its function? Factor 13 does not activate anything. If you look at the other clotting factors, they're responsible for activating the next factor also, right? They play a role there also. Factor 13, what it does, whatever the fibrin is formed, it forms covalent bonds between them. So it helps in making the fibrin strong. Okay? So that's the main function of fibrin stabilizing factor 13. And it's very important at birth. At birth, where do you find rich concentration of factor 13? At the umbilical stump site, right? So if a baby is having prolonged bleeding from the umbilical stump site, you have to think about factor 13 deficiency. But in adult, the main role of factor 13 is to make the net, the fibrin net, strong. Why do you want to make it strong? Because it will go and get deposited on the temporary plug, and whatever other cells are there, it will trap it. So when it's trapping more and more cells, this clot is getting solidified. So it will make it stay in place for a longer time. Sorry, did I answer your question?
Yes, thank you.
Okay. Next, let's continue now here. I know it's too much writing, but I just want to put everything in one diagram here.
So, Rajna,
Yes.
say that the fibrin activates factor 13.
Initially, the formation of unstable fibrin. So as soon as the first stable fibrin plug is formed, yeah, that is responsible for activating the factor 13.
Okay, thanks.
Okay, but factor 13, no, it does not help in formation of fibrin. That's what I was trying to tell. Fibrin is already formed. What it does, it forms covalent bonds between the adjacent fibrin strands and make it more solid. Yeah, but yes, 13 is activated once this fibrin strand is formed. That leads to activation of factor 13. Correct.
Thank you.
Okay, which ion you need for the activation of clotting factors?
You require calcium, but you also require the phospholipid surface of the platelets, right?
Correct. And which vitamin do we need?
Vitamin K,
Vitamin K. Which are the vitamin K dependent factors?
2, 7, 9, 10.
2, 7, 9 and 10. Good. Now, give me a drug which inhibits thromboxane A2. Aspirin. Good. And where do we use aspirin?
On the COX.
Prophylaxis.
No, the stroke, right? Isn't it for the myocardial stroke or something?
Correct. So it inhibits the cyclooxygenase enzyme. Thereby it inhibits thromboxane A2. So it is used as a prophylactic drug for prophylaxis to prevent a clot or minimize the risk in patients with myocardial infarction or an ischemic stroke. Okay, so that's the use of aspirin. If it inhibits thromboxane A2, which step will it inhibit?
The platelet addition.
Activation.
Look at the diagram. If it inhibits thromboxane A2,
Platelet aggregation.
platelet aggregation. Okay, so aspirin inhibits platelet aggregation. If you don't have glycoprotein 1b or von Willebrand factor is not there, which step will be affected?
Platelet adhesion.
Platelet adhesion. If you don't have glycoprotein 2b or 3a, which step cannot happen? Platelet aggregation. So platelet aggregation cannot happen. Which are the naturally occurring anticoagulants? Give me some naturally occurring. You're right, somebody told. It's HAT. Heparin, antithrombin 3, thrombomodulin. So heparin will bind to antithrombin 3 and it will go and inhibit thrombin. Thrombomodulin by itself will go and bind to thrombin. So overall, what does HAT do? All the three will finally go and block thrombin. So because it blocks thrombin, there is no fibrin formation, and that's why there is no clot formation. So that's why in you and me, our blood is generally in the fluid state because of HAT. Okay? Which are the artificially derived anticoagulants in the laboratory? These anticoagulants target the activators. And which are the activators? Vitamin K and calcium. So give me drugs which target calcium.
Oxalate and citrates
So
and ETA.
yeah, I told some of you, calcium is C. So remember it as CEO. Citrates, EDTA, oxalates. So CEO blocks calcium, citrates, EDTA and oxalate. The difference being Citrates and oxalates are irreversible. EDTA is a reversible agent. Give me vitamin K antagonists.
Warfarin,
Warfarin and dicumarol. So if you give warfarin or dicumarol, 2, 7, 9, 10 cannot get activated. So that's pretty much with clot formation. So now what happened? The definite clot remained there, the blood vessel healed, and everything went back to normal. So now you don't want the clot to be there because it can lead to embolism. So give me a fibrinolytic agent which goes and breaks the clot.
Streptokinase.
plasmin,
Now I'm talking about a normal fibrinolytic agent, plasmin. And the precursor is plasminogen. And what's the enzyme which converts plasminogen to plasmin?
TPA.
TPA,
Tissue plasminogen activator. So once the clot is formed, someone should tell TPA to get activated, and that will convert plasminogen to plasmin, and plasmin breaks the clot. So if I ask you what causes fibrinolysis, I'm asking you what causes breakage of clot. Your answer has to be plasmin. Don't tell HAD because HAD doesn't break the clot. Okay? But HAD does help in the sense thrombomodulin, like calmodulin binds to calcium. Therefore, thrombomodulin binds to thrombin. So what does this complex do? It has a stimulatory effect on the TPA. So that's what will tell the TPA to convert plasminogen to plasmin, and finally the clot will break. And the blood vessel is now normal. What's an abnormal clot formation known as?
Thrombus.
Any abnormal clot formation is called as thrombus formation or thrombosis. What's predisposition to clot formation? For any reason, if the blood is accumulating. So give me some conditions where the blood accumulates in a segment of the vessel.
Stasis.
Stasis due to prolonged bed rest or immobility. If you're not moving around.
Sickle cell anemia.
Or there is increase in viscosity of blood. That could happen because of cells sticking together, sickle cell anemia, or a simple polycythemia. Okay, so stasis of blood due to prolonged bed rest, increase in viscosity, or any sluggish circulation can cause abnormal clot formation, which can break free and give rise to embolism. Okay, so this embolus can travel to the heart, giving rise to myocardial infarction, travel to the brain, resulting in stroke. So now you take a CT scan and you see a clot. What's the drug of choice?
aspirin,
Aspirin won't break the clot. Aspirin will prevent further clot formation, which is the
Thrombolytic like streptokinase.
now it will be streptokinase. See, because to break the clot we need plasmin. So what's the action of streptokinase? It stimulates tissue plasminogen activator, which will convert plasminogen to plasmin, and this plasmin goes and breaks the clot. So it could be used in MI. And what type of stroke? You have two types, ischemic and hemorrhagic. So in which stroke will you give streptokinase?
Ischemic.
Ischemic stroke. It is contraindicated in hemorrhagic because it will make the bleeding worse, right? So it's given in only ischemic stroke. With that, now let's go to the disease. So this table I've given you before. Tell me about the disease. You talk about the disease and give me what's the pathology or what is affected because of the disease. Bleeding time, you told me, test for the temporary plug formation. And what does the clotting time test for? The
Fibrin formation.
fibrin
the
formation.
for fibrin thread,
Correct. Prothrombin time test for
Extrinsic and common pathways.
extrinsic as well as common pathway. PTT test for or activated partial thromboplastin test for
intrinsic and common pathway,
intrinsic and common pathway. Good. Give me some liver disease. Name a liver disease.
Cirrhosis.
Hepatitis.
Alcoholic cirrhosis. Good. Hepatitis. Good. So if the liver is affected, what's the problem?
Failure to synthesize clotting factors.
Clotting factors cannot be synthesized. So what happens to the time test? Bleeding time,
is normal,
it does not affect temporary plug. So bleeding time is normal. Clotting time will be
increase,
increased. Any liver disease affects the common pathway. And I've told you before, if common pathway is affected, what will happen to PT and PTT?
Both will increase.
Both will increase. Good. Vitamin K deficiency. Give me some conditions where we are prone for vitamin K deficiency.
Breastfed children.
Newborn
Babies,
babies who are breastfed. So if it's a breastfed baby, you think about vitamin K. If it's umbilical stump bleeding, you think about what?
Factor 13.
Factor 13. Okay, breastfed baby. And since vitamin K is fat soluble vitamin, any problem with fat absorption? For fat we need bile, which is synthesized in the liver. So any problem with liver or any problem with site of absorption, intestine. So before performing any surgery on the liver or intestine, what do you give as prophylaxis?
Vitamin 12 K injection.
Correct. So if there is a liver problem or intestinal problem, we anticipate vitamin K deficiency and give vitamin K shots. So how do you know there's a problem with fat absorption? So any problem with fat absorption can give rise to vitamin K deficiency. So your vignette may not give you the exact diagnosis. They might just tell the person has diarrhea. Diarrhea means where is the problem?
GI.
GI problem. Or they might simply tell the patient has steatoria. Steatoria means what?
Fatty, bulky stools.
Bulky, fatty, foul-smelling stools. So that again tells you that fats are excreted, they are not being absorbed. So you have to think that it is vitamin K deficiency. Good. So what's the pathology? Which factors will be less?
2, 7, 9, 10.
2, 7, 9 and 10. So tell me the time test. Plug, is it affected?
No.
Oh, no.
No,
Sorry, no.
plug is not affected. Clotting time will be
Affected. High.
prolonged. 2, 7, 9, 10. It will affect the common pathway. So what will happen to PT and PTT?
Increase. Both.
Both increase. Good. What is ITP?
Thrombocytopenia.
Idiopathic thrombocytopenic purpura. The name is self-explanatory. So what happened here?
You have a decrease in platelet count, pretty much.
Thrombocytopenia means decrease in platelets. And what is purpura? That's the main clinical feature. So what does purpura indicate?
Petechiae?
Petechiae or purpura are small spots. So these small bleeding spots, you're right, good, indicates bleeding from capillaries and venules. So in you and me, capillaries and venules stop bleeding spontaneously thanks to our platelets. These guys don't have enough platelets, so even capillaries and venules will bleed, giving rise to small hemorrhagic spots. So if platelets are less, what will happen to the plug formation?
Increased.
So bleeding time will be prolonged. CT,
Normal.
everything else remains normal.
Normal.
Good. Next, what's hemophilia A?
Factor 8 deficiency.
Factor 8 is deficient. What's the other name?
Classical.
Classical. Hemophilia B, deficiency
Christmas
of
disease.
9. So it's also called as Christmas disease. So 8 or 9 doesn't matter. The time test will be the same. So what is it affecting? Plug. So temporary platelet plug, what will happen to it? Will it be affected?
No, it'll be normal.
It will be normal. Bleeding time is normal. But fibrin is affected. So what will happen to clotting time?
Increase.
Increased. 8 and 9 belong to which pathway?
Infant.
So PTT is prolonged. PT is normal. What's von Willebrand disease?
Deficiency of von Willebrand factor.
Good. So the minor form, the von Willebrand factor is slightly reduced. It is only slightly reduced. So factor 8 survival is not affected. But in a more severe form, the von Willebrand factor is decreased significantly. So as a result of that, it cannot hold on to factor 8. So subsequently, the factor 8 gets destroyed easily and there is factor 8 deficiency. Whereas hemophilia A is a problem with factor 8 production. You don't have enough levels of factor 8. They are not produced. Whereas in severe von Willebrand disease, So minor von Willebrand disease and severe von Willebrand. Factor VIII production is not the problem, but because the von Willebrand factor decreased significantly, it could not hold on to factor VIII and increase the survival. So in that process, factor VIII gets easily destroyed. Based on minor or severe, in minor first tell me, only the von Willebrand factor is affected. So which is the step which is affected?
Bleeding time increases.
Bleeding time increases, everything is fine, everything else. Severe form, von Willebrand and factor VIII are less. So what will happen to bleeding time?
Increase more and more.
Correct. Clotting time,
Decrease.
8 belongs to,
Intrinsic.
so
Intrinsic.
PTT will be prolonged, PT will be normal. And that concludes coagulation. How are we on time? It's 3:50. Do you want a break?
It's up to you, Dr. Kaji.
Yeah, we can take a break.
You want a break? Okay, I'll see you at 4 then. And then we'll start renal, okay?
Sure.
Dr. Prajna, was EDTA reversible or irreversible?
EDTA is reversible
Thank you.
because it's used for therapeutic reasons. So if you are using it for therapeutic, it has to be reversible, okay?
And sorry, I heard you say, you know, when you said that if you ask what breaks the clot, you want us to say plasmin.
Correct.
But the streptokinase is what drug will help break the clot?
Correct. So if I ask you, normally, in a normal person, what's responsible for removal of the clot once the vessel has healed? Your answer,
Oh,
you should tell me
plasmin.
plasmin. But in a patient, I'm telling you which drug will cause the breakage of clot. You're right, streptokinase does the same thing. But normally we don't have streptokinase, right? Normally our thrombomodulin thrombin complex is enough to activate our plasminogen to plasmin.
Okay.
So I was asking normally what breaks this clot. So I would expect you to tell me plasmin, not streptokinase.
Okay.
Dr. Praj, also a question. So if you ask which substance can activate TPA, would either answer be acceptable of streptokinase or the complex of thrombomodulin?
No, I will have to give you a vignette which is suggested. So in anything I'm describing in a patient, you have to tell streptokinase. If I'm telling you in a normal physiology what causes breakdown. So that should be thrombomodulin thrombin complex, which activates TPA, which releases plasmin. So physiologically, if I ask you, tell me thrombomodulin thrombin complex. In a patient, if I'm asking you, give me streptokinase.
Okay, thank you.
No worries. Okay, guys, we have everyone back. I think so. Can you hear me?
Yes.
Okay, thank you. Give me the diagnosis. What's the diagnosis here?
Von Willebrand disease.
Yeah, what's the disease?
Von Willebrand.
So minor, it could be seen in minor von Willebrand disease. Or what's the other one where the platelet plug is prolonged?
Thrombocytopenia.
So idiopathic thrombocytopenia. Good. So here what happened? Clotting time and PTT got prolonged. So it has to involve clotting factor belonging to which pathway?
Intrinsic.
Intrinsic.
pathway.
So give me the disease.
Hemophilia A or B?
Correct.
Hemophilia A and B.
Correct. Either hemophilia A or B. Good. So here bleeding time is normal, clotting time is prolonged, PT and PTT are prolonged. So that means which pathway is affected?
Common and intrinsic and extrinsic.
The
Correct.
both intrinsic and extrinsic pathways.
So it should be a disease affecting the common pathway. So what are the diseases which can affect the common pathway?
Liver disease.
Liver disease and vitamin K deficiency. So are you getting what I'm trying to convey here? On exams, you might get a time test value and the normal value will be given. So based on that, again, you might have to interpret. So just go by the logic. Okay, bleeding time is affected. That means platelet plug cannot be formed. Clotting time is affected. That means the clotting factor has to be affected. And then take it from there. Okay, let's move on to renal. Give me the cells of the juxtaglomerular apparatus, which is a cross section between the glomerulus here and the early distal convoluted tubules. And what are those modified cells called as?
Macula densa.
Macula densa. So what are the three cells of juxtaglomerular apparatus? Macula densa cell and then what?
JG cell
What?
Mesangial.
Mesangial
and
cells
mesangial.
and JG cells, otherwise called as granular cells. And what are the functions? JG cells secrete
Renin.
renin, which has a role in regulating blood pressure. If a renin is dealing with blood pressure, so what should be the stimulus for release of renin? Decreased blood flow. Okay. Whereas erythropoietin is dealing with erythropoiesis, oxygen. So a loss of oxygen will stimulate release of erythropoietin. Mesangial cells and the macula densa cells. Mesangial cells can contract. And what does the macula densa cells secrete?
Adenosine.
Adenosine. So both of these have a role in auto-regulation of renal blood flow and GFR. So know the different cells of juxtaglomerular apparatus and their functions. Since we are talking about auto-regulation, tell me about auto-regulation. What is the auto-regulatory range of mean arterial pressure given in millimeter mercury?
80 to 200 mm per mercury.
Correct? 80 to 200 millimeter mercury. Which means that when the pressure increases from 80 to 200, our GFR is maintained at the rate of 125 ml per minute. That's the GFR. And the renal blood flow is maintained at 1200 ml per minute. So between this range. But below that, when the pressure falls below 80, that means there's less blood flow. That means GFR is also less. If the pressure goes above that, that means the blood pressure is high, blood flow is high, GFR also increases. So why between this range? It's because of autoregulation. To understand autoregulation, which is the equation I asked you to use? Blood flow equal to?
Change in pressure gradient over R.
So Q is equal to delta P over R. So according to the equation, when your mean arterial pressure increased, what should have happened to the blood flow? It should increase. That's straightforward. That did happen. So what happened as the renal blood flow increased? Tell me about the myogenic mechanism. How did I ask you to remember this? Myo has to do something with muscle, smooth muscle cells. That's the mesangial cells. So when renal blood flow increased, what happened to your efferent arterioles initially? It got
Constricted.
it got stretched because of the volume, right? And this stretch will cause opening and activation of which channel?
Calcium.
Calcium. And because of calcium release, what happened to the mesangial, the smooth muscle derived cells? The mesangial cells will contract. So imagine you have the mesangial cells around the afferents. Because they contract, what will happen to the afferent arterioles?
Sure.
Constrict. And when afferent constricts, what happened to the resistance it offered? Increased. Because of that, it nullified the original effect. Both increased proportionately. It will cancel each other. And what happened to our renal blood flow and GFR? It was brought back to normal. The next mechanism is the tubuloglomerular feedback mechanism. So what happened here? Here, break the word. Tubuloglomerular. It's an interaction between the glomerulus and the tubule. And which tubular segment we are talking about? Early distal convoluted DCT. So again here what happened? Initially when pressure increased, according to the equation, the blood flow increased. And as the blood flow increased, hydrostatic pressure will increase. And what happened to the GFR as well? Increased. Due to which filtered load is plasma concentration times GFR, right? So even the filtered load for sodium chloride will increase. Due to which lots of sodium chloride will enter the tubules. Too much of sodium chloride will reach the early distal convoluted. And this is sensed by which cells?
Macular denser.
Macular denser cells get activated and they will secrete what?
Adenosine.
Adenosine. And what is the role of adenosine? It will go back and act on the efferent arterioles, and adenosine causes efferent arteriolar constriction. Following that, what happened to the resistance? Increased. So they cancelled each other, by which the blood flow and GFR came back to normal. Okay? So they ask you this, the autoregulatory mechanism, which is the main seat of control. So when pressure increased, blood flow also increased. So what brought back this change to normal? An increase in resistance. And at which site there was an increase in resistance? Efferent arterioles. So the seat of control is the efferent arteriolar resistance. Did you get this?
Yes.
Okay. Next, we'll talk about the three layers of the glomerular membrane, which is a cross section here. So from top to lower down, you have the capillary endothelium, basement membrane, and the epithelial layer podocytes have food processes. The epithelial cells have, podocytes of food processes, which form these narrow filtration slits. What's the nature of the capillary endothelium?
It has fenestrations.
Fenestrations, it has pores. Basement membrane, what's the unique feature?
Negative.
Negative charges, so it repels proteins. Fenestrations or pores will repel RBCs. Basement membrane will repel proteins. Give me a disease where the basement membrane negative charges are lost.
Nephrotic.
Good. Nephrotic is non-inflammatory. Autoimmune condition where the antibodies cause structural damage to basement membrane. Negative charges don't repel proteins. Proteins are allowed to pass. So the main clinical feature is proteinuria, and clinically this is seen as, you have already told me this, foamy frothy urine. Because of proteinuria, what effect does it have on the colloid oncotic pressure?
Decreases.
Colloid oncotic, good, it's in the blood. So because you're losing proteins, your blood proteins will decrease and the colloid oncotic pressure will decrease, and that's what results in edema. So in nephritic, itis is inflammation. So what happened in nephritic syndrome? What's the change during inflammation?
Pore size increases.
Pore size increases. So now it will allow RBCs to pass. and passage of RBCs in urine. What's the main important clinical feature here? Hematuria. So this is the foremost clinical feature. But of course, because the pore size increase, too much proteins also get filtered. It might lead to mild proteinuria because the negative charges are still there. They might repel the proteins. But because of excessively being filtered, some proteins will escape. And then because of inflammation, scarring is caused and the basement membrane becomes thick. So it will not allow which substances to pass from the blood?
BO1 and creatinine.
Urea and creatinine. So their levels will increase in the blood. And what is that called as?
Azotemia.
Good, azotemia.
And it can lead to uremia as well.
Uremia as well, which is end-stage renal disease. Yes, Chinay?
Sorry, could you go over that azotemia step just one more time? I just missed that. Sorry.
Sure. So any inflammation can be followed by scarring. So post-inflammation, if the inflammation is prolonged, what can it can lead to scar tissue formation, and because of that, the basement membrane becomes thick, due to which normally you had waste products in the blood, urea and creatinine. So it's the rule of diffusion also. If the membrane is thick, the substances cannot pass easily. So urea creatinine cannot excrete easily, so they start accumulating in the blood, and increased urea creatinine in the blood is called as azotemia.
Thank you.
So that is all seen in nephritic, but it will of course take some more time. The first change is increase in pore size, hematuria. Okay, so let's move on. Next we'll talk about Starling's forces. Like systemic capillaries, glomerular capillaries also have hydrostatic pressure in the capillary, hydrostatic pressure in Bowman space, colloid oncotic pressure in the capillary. Since there are no proteins in the space, you don't have oncotic pressure in the Bowman space. In the kidney, you want only filtration to take place at the glomerulus. You don't want the fluid to go back, because of which hydrostatic pressure is high and it remains constant throughout. Okay, and the hydrostatic pressure in the blood vessel, hydra, it depends on the fluid in the blood vessel. And what's the fluid in the blood vessel we are talking about? The blood flow, blood. So hydrostatic pressure depends on blood, oncotic pressure depends on proteins. And what does the hydrostatic in the Bowman space depend on? Which hydra?
Fluid.
Tubular fluid, correct. Okay. So give me conditions where hydrostatic pressure in the capillary increases. That means there has to be more blood. What are the possibilities?
Efferent arteriolar constriction.
Either in efferent arteriolar constriction, more blood will accumulate, or afferent arteriolar dilation. Okay, so increased blood can be seen if efferent is constricted due to stasis of blood, or if the afferent is dilated because more blood entering the capillaries. Give me a condition when hydrostatic in the Bowman space increases.
Constriction of the ureter.
If there is an obstruction to the outlet, any ureteric obstruction. Give me causes for ureteric obstruction.
Nephrolithiasis.
Benign hypertrophy.
Calculi, benign prostatic hypertrophy, or any tumor compressing on the ureters. So that will cause fluid won't be able to leave. That will cause a back pressure. So all the fluid starts accumulating here, and that will increase the hydrostatic in the Bowman space. Next, okay. So as long as you have a net filtration pressure, you have a number, the fluid is being filtered. But after some time, you want the fluid filtration to stop, or any substance filtration to stop. So when the filtration stops, that's called as the filtration equilibrium. That means your net filtration pressure has gone to 0. Out of these pressures, which pressure is responsible for filtration equilibrium?
Capillary oncotic pressure.
The increase in capillary oncotic pressure by the time it reaches the efferent ends. And why is it increasing? We have already done this many times. Because of fluid getting filtered, proteins not being able to pass, proteins get concentrated. So by the time blood enters the peritubular capillary, the oncotic pressure is very high, and that's the one which favors reabsorption of solutes. Okay. And because the oncotic pressure increases, at some point the filtration pressure becomes 0. So we have hydrostatic in capillary, say 40 millimeter mercury, hydrostatic pressure in Bowman space 10, and oncotic pressure is say 15. So calculate net filtration pressure. What's the equation?
KF.
No, net filtration pressure. You're telling me GFR.
GC minus Bowman space hydrostatic pressure minus capillary oncotic pressure.
Good. Hydrostatic pressure in the glomerular capillary minus Bowman space minus colloid oncotic pressure in the capillary. And according to the formula, you add the values. Don't substitute sign. So it will only be 40 minus 10 minus 15. How much is the net filtration pressure?
15.
15, 25, 40, 15 plus 15. Good. So that's the net filtration pressure, which is positive, which causes fluid to filter. So at what point net filtration pressure becomes 0? That means the oncotic pressure should increase by 15. So what was the original oncotic pressure?
15.
15. So what will be the new oncotic pressure in the capillary at filtration equilibrium? 30 millimeter mercury. Because 15 was already there, and for that you added 15. So when the colloid oncotic pressure increases by 15, that means your net filtration pressure now will be 40 minus 10 minus 15 plus 15 is 30. So when you take a sum of this, it will become 0. So whatever gradient is there, your oncotic pressure should increase by that much. Next was the calculation of GFR based on this. That I think you told me before this. Filtration coefficient times hydrostatic in capillary minus Bowman space minus oncotic in the capillary. What favors filtration out of all these pressures? Hydrostatic in capillary favors and the other two oppose. What's the definition of filtration coefficient?
Permeability to water.
It's called water permeability. Good. So if you know the basic definition, any question I ask, you should be able to answer. If I tell patient is diabetic, which has caused thickening of the basement membrane, what will happen to the water permeability, KF?
Decrease.
Decrease.
Basement membrane is thickened. So can the water flow easily or difficult?
Difficult.
Difficult. So filtration coefficient, permeability is less. And if permeability is less, what will happen to GFR?
Decrease.
Decrease. Or any disease where surface area is destroyed. Again, the permeability will be less, GFR will be less. Immediately following inflammation, what's the first change during inflammation? Increase in pore size. So if the pore size increases, what will happen to the water permeability?
It will increase.
GFR will also increase. But of course, after a certain time, inflammation is followed by scarring. So then it will change. I'm asking you immediately following inflammation. Okay? If you give a vasodilator drug, what do you think? More blood is entering. So what will happen to the permeability?
Increase.
Hydrostatic will increase, permeability will increase. So what will happen to GFR? Increase. If you give a vasoconstrictor, less blood means less pressure, coefficient will be less, GFR will be less. Next, so we did Starling's forces and the different calculations. Now finally, tell me the condition. What happens to hydrostatic pressure in the capillary? Based on that, tell me what happens to GFR. What is renal plasma flow or the nephron plasma flow? Flow in which segment?
Peritibular.
Peritibular
capillaries. Because it's that blood vessel which is supplying majority of your tubules, cortical tubules. It's mainly the peritibular capillary. Based on that, comment on peritibular capillary pressure. And finally, comment on filtration fraction. What is the equation for filtration fraction?
GFR over RPM.
GFR over renal plasma flow. So G comes before R. So G should be on the top. So we'll talk about efferent dilation, Efferent constriction. What causes only the efferents to constrict?
Normal levels of angiotensin
Normal, you mean low or high?
II. Low.
Low levels of angiotensin 2 will act only on the more sensitive end, and the more sensitive end for angiotensin 2 is efferent. So low angiotensin 2 will constrict only the efferent. What will constrict both efferent and efferent?
High levels of angiotensin II.
Good. High levels of angiotensin 2 and what else?
Sympathetic.
Good. Sympathetic stimulation. They will confuse you telling that there is more alpha 1 on the efferent, but also remember that there are alpha 1 on the efferent as well. So sympathetic will act anywhere where there is alpha 1, so both will constrict. High angiotensin 2, of course, because its levels are high, it will constrict both. And the last one would be ureteric obstruction. So in ureteric obstruction, you have to remember that nothing was wrong with the capillary. So capillary, everything was okay. But which pressure increased because of accumulation of fluid in the tubules?
Bowman space hydrostatic pressure.
Hydrostatic pressure in the Bowman space increased. Does it favor or oppose?
Oppose.
Oppose. So what happened to GFR?
They will decrease.
Decrease. So if less fluid is filtered, there is more going to the peritubular capillary. Due to which what happens to filtration fraction? If so, one is decreasing, other is increasing. Some of you are getting confused. So at least related to the numerator. What's happening to the numerator?
Decreasing.
Decreasing. So what should happen to the filtration fraction? Decrease. Okay? Because they're directly proportional. Start efferent dilation. What happened? What happened to the hydrostatic pressure?
Increases.
GFR.
Increases.
Peritubular renal plasma flow and pressure.
Decreases both.
Pardon me?
Decrease.
You say D or I?
They both
Increase.
See, the efferent is dilated. So the amount of blood entering itself is less. So any change with efferent will affect everything uniformly. So if you have more blood entering, there's a uniform increase in all the segments. Due to which what happens to the filtration fraction?
Normal.
Because of the uniform change, both numerator and denominator change uniformly, filtration fraction will be normal. If the efferent is dilated, it's a different story because the amount of blood entering was fine. But because of dilation here, more blood went to the peritubular capillary. So the peritubular capillary flow and pressure increased. So what happened to the blood remaining in the glomerular?
decreased.
Decreased. So what will happen to the filtration fraction? Numerator has decreased,
Decrease.
so it has to decrease. Again, efferent constriction. So any change with efferent will affect everything uniformly. So if the efferent is constricted, what happens to blood flow?
Decreased.
Blood flow everywhere will decrease uniformly. And because of that, if it's a uniform decrease in both, filtration fraction stays normal. Low angiotensin 2 will constrict the efferent. So what will happen? Where will the blood accumulate?
Glomerulus.
Glomerulus, GFR will increase, and the blood going to the peritubular capillary will be less. And what happens to the filtration fraction? Numerator is increasing. So what should happen to the filtration fraction? Increase. What happens when both are constricted? This is different. There is one constriction, so the amount of blood entering is less. But because of the second constriction, what happened to the blood going to the peritubular capillaries?
Significantly.
It dropped much more. So as a result of that, what happens to filtration fraction? Numerator was less, denominator became much lesser. So in math, if the denominator is much lesser, what happens to the filtration fraction? It will increase. And that's pretty much with topic 1. Do you have any questions?
Did the uteric, the obstruction one decrease with the filtration fraction?
Correct.
Okay.
Next, we will define some things. We define GFR, which is expressed in ml per minute. We'll define filtered load and excretion, both of which are expressed in milligrams per minute. And then we defined clearance, which is again expressed in ml per minute. So these two are expressed in milligrams. So we are defining solutes here. These two are expressed in ml per minute. So we are defining fluid. What's the difference between GFR and clearance? GFR is the rate at which fluid is filtered at the glomerular capillaries. Okay, so GFR is the rate of filtration of fluid at the glomerulars. And what is clearance? It's the fluid in the peritubular capillaries. It's the volume of fluid in the peritubular capillaries from which a particular substance has been removed. Now filtered and excretion are defining solutes. So what is filtered load? It's the rate at which a substance is filtered across the glomerulus. So that's the difference between GFR and filtered load. GFR is the fluid being filtered. Filtered load is the substance being filtered. And excretion, the rate at which the substance is excreted. Therefore, your filtered load will depend on the blood values because it's here. And what's the formula for filtered load? It depends on the blood. So plasma concentration, it's a rate. So what's the rate it will depend on?
GFR.
GFR. Excretion is in the urine. So instead of plasma concentration, it will depend on urine concentration. Instead of GFR, it will depend on urine flow rate. And what's the equation for clearance? It's excretion over plasma. So what is the equation for clearance?
UV over P.
UV over P. So you have to know these equations. You will have problems on this. You have to know it. Okay. If you get stuck, go by the definition and try to derive it. Okay. So based on that, if I give you data, you calculate filtered and excretion. If filtered load is 400 milligrams per minute, excretion is 100 milligrams per minute. Comment on the renal handling. And by renal handling, I'm asking you what happened when the substance went into the proximal convoluted tubule. Filtered was 400 in any part of the tubule. Excretion was only 100. So what happened to the substance?
Reabsorbed.
It got reabsorbed. And how much was reabsorbed?
300.
300 milligrams per minute. If filtered is 200, excretion is 500. Then what happened to the substance?
Secreted.
Because secreted.
It got secreted. Yes, and how much?
300.
300 milligrams per minute. Good. If filtered is 0, excreted is 0. What are we looking at?
Albumin.
Albumin. Good. Proteins, because its filtered load itself is 0. Proteins or albumin. If filtered is 100 milligrams per minute, excretion is 100 milligrams per minute. What are we looking at?
Inulin.
Whatever was filtered is getting excreted. So it's neither reabsorbed nor secreted. So we are looking at inulin. If filtered is 100 milligrams per minute, excretion is 0. What are we looking at?
Glucose.
Glucose. Because even though it got filtered, it got completely reabsorbed. So what happened to the excretion? 0. Got this?
Yes.
Okay. So that's why you have to know the equation. Okay. Next is clearance is UV over P. So if clearance of a substance is increased, that means numerator is increased, denominator is decreased. Comment on what happened to the substance. It's leaving the plasma. So what happened to the substance?
Secreted.
Secreted. If clearance is decreased, that means excretion has decreased and denominator has increased. It's staying in plasma. So what happened to the substance?
Reabsorbed.
Reabsorbed. If clearance is 0, that means the numerator is 0, right? UV is 0. That means this is a substance which is not excreted. Which substance are we talking about?
Glucose, a protein.
Glucose or even proteins, because they are not getting filtered, their clearance will be 0. So how will you differentiate between the two? proteins, the filtered load and excretion is 0, whereas glucose does get filtered and only the excretion is going to be 0. So filtered there will be a value and only excretion is going to be 0. Next, let's talk about inulin. And what's the nature of inulin? As you told, it gets filtered and rest remains in the peritubular capillary. But in the tubular segment, it has no proteins, so nothing will happen here. Therefore, whatever is filtered gets excreted. Therefore, let's go to clearance of inulin. It's the volume of plasma from which inulin is removed. So if I ask you, the clearance or removal of inulin depends on only one process. What is that?
GFR.
It only depends on GFR, which is 125 ml per minute. So what's the volume of plasma which removed inulin? That's clearance is going to be 125 ml per minute. It's exactly equal to GFR. So every minute 125 ml of a plasma is removing inulin. Since it's dependent on GFR, it will not get saturated. So even though it gives a value exactly equal to GFR, it has to be injected. So we don't prefer it to measure GFR in patients. Suppose like in filtered load, which is plasma concentration times GFR. If I don't give you GFR, I give you clearance of inulin, you can use that. Okay? Because GFR is nothing but clearance of inulin. Therefore, we need another substance, and that substance is creatinine, which is generated in your body. Majority of it gets filtered with GFR. Rest of it enters the peritubular capillary, where the basolateral surface has say 1 or 2 carriers through which a very minimal amount of creatinine gets secreted. Therefore, what's the volume of plasma from which creatinine was removed? Approximately 95% depends on GFR and a 5% more gets secreted. So what will be the volume of plasma which removes creatinine? It will be 125 ml plus, say 5 ml more of plasma removed creatinine. So it will be plus 5 ml more because small amount got secreted. So therefore, clearance of creatinine will be slightly more than GFR. Say it's around 130 ml per minute, but it's close enough. Therefore, clinically we use creatinine to measure GFR because you don't need to inject anything, it's found in your body. And since 95% depends on GFR, even creatinine does not get saturated. Even if it keeps on producing, it will be maintained at that steady state, slightly above GFR. Next, PAH. So whenever you inject PAH, everything enters the renal circulation because only the kidneys can handle PAH. 20% of PAH gets filtered. Rest of the 80% enters peritubular capillary, where you have abundant carriers, due to which what happens to all the 80% of PAH present in the blood? All the 80% gets excreted. So clearance of PAH, 80% is dependent on secretion and only 20% is dependent on GFR. So clearance value will always be GFR plus something. It will always be above GFR. Okay? So after it's secreted, does the plasma have any PAH? No. So suppose you have 600 ml, which is the renal plasma flow. The clearance of PAH is the volume which removed PAH. So what's the volume of plasma which removed PAH? Does your plasma have any PAH after this?
No.
No. That means your entire 600 ml removed PAH. Therefore, what's the volume which removed PAH? Is the entire 600 ml, which is a measurement of the renal plasma flow. So clearance of PAH gives you the effective renal plasma flow because it underestimates by about 10%. It does not give you actual value because part of pH goes to the capsular region and the fat area. That is actually not removed. Okay, but that's close enough. That will give us a good idea about the renal plasma flow. Last one is glucose. Glucose, what happened? It got filtered, rest remained in the blood. and everything got reabsorbed. So initially clearance is UV over P, nothing was excreted, so clearance was 0. So what does that mean? Clearance of glucose is the volume of plasma which removed glucose. All the glucose went back to the plasma. There was no volume of plasma which was removing glucose. That's why clearance of glucose is 0. But once carriers get saturated, it starts getting excreted. And if excretion increases, what will happen to clearance of glucose? It will increase. But because it was reabsorbed, its clearance value will always be less than GFR. So another way of asking this would be, if clearance of substance A is greater than clearance of inulin, that means it's greater than GFR. Okay, so if clearance of a substance is greater, that means it's leaving the plasma. So what happened to the substance?
Reabsorbed.
Clearance of a substance is greater than the amount filtered. So if clearance is increased, that means excretion has increased, it's leaving your plasma. So what's happening to the substance?
Secreted.
Secreted. Okay. If clearance of substance B is less than clearance of inulin or less than 125 ml GFR, that means this substance has a low clearance. That means less is excreted, more is remaining in the plasma. So now what happened to the substance?
Reabsorbed.
It is reabsorbed. Good. And if clearance of substance is 0, that means excretion is 0. Right? And the possibilities are glucose and proteins. They're not getting excreted.
Dr. Prajna, you see the arrows that you have at the top? Like, so if the clearance of substance is greater than GFR, it's glucose. I'm confused.
Pardon me?
What is the substance? You see how you have, like, if the clearance of a substance is greater than inulin, that means it's greater
I
than
just gave A
GFR.
and
What's
B.
the
I
answer of
will
that
just,
substance? Sorry?
yeah, I want you to tell me what it is. So I just told you some imaginary substance A. Its clearance is greater than the amount filtered, GFR. Okay? So say GFR was 125. Okay? Clearance has increased. And if clearance has increased, the numerator has increased. That means more of the substance is getting excreted. So I just want you to comment on what happened to the substance. Was it reabsorbed or secreted? First define that. First determine that. Janai, are you with me?
Sorry, yeah. Is that secreted?
Yeah, it is secreted. So then what are the possibilities? Either it could be PAH or
Right.
slightly more it could be creatinine.
Okay.
If clearance of a substance is less than clearance of inulin, that means this substance was reabsorbed. Because if clearance is less, plasma concentration has increased. So it can be any substance which is reabsorbed. Sodium, potassium, urea, etc.
Okay.
For glucose, clearance has to reach 0. Complete reabsorption.
Okay.
Okay? You got it, Janai?
I think so. I might just have to watch it again.
See, whenever I ask you anything about clearance, simply use it for UV over P. So I'm telling you if clearance is more than inulin, that means it has a high clearance. High clearance means numerator has to increase, denominator has to decrease. Then visualize it. This is a substance which is excreted more and it is less in the plasma. So is it entering the plasma or leaving the plasma?
Leaving.
Leaving. So what's happening to the substance? Secreted. If clearance is less, excretion is less, denominator is more. Visualize it. The excretion is less, plasma concentration is more. So is it entering the plasma or leaving the plasma?
Entering.
So that is reabsorbed.
Right.
Okay?
Yeah, thank you.
No worries. After that it is free water clearance, which is the solute free water. And what's the formula for that? Volume of urine minus UV over P, but here it is osmolarity because We are calculating clearance of osmotic particles. So if the value you get is say +2, positive, we are talking about urine here, okay? Free water clearance is in the urine. So if the value is +2, that means urine has more water or less water?
More water.
More water. So what's the nature of urine? Hypotonic or dilute. Therefore, what happened to ADH? High or low?
Low.
We excrete water when ADH is less. Give me the disease. Diabetes insipidus. Or what else can suppress ADH? Alcohol intoxication.
Polydipsia.
Polydipsia. When you drink too much of water, you'll have dilute urine. If free water clearance is negative, say -1, you have deficit of water. So urine is hypertonic, which is concentrated. So what happened to ADH? You're retaining water. So ADH has increased. Disease would be SIADH. And when do you pass concentrated urine? When we are dehydrated or when we are deprived. Water deprivation. Okay? If free water clearance is 0, what does it mean? You don't have any free water. So what urine are you passing? Isoosmotic, which is called as isostinuria. And now we have done the drugs which can cause this. If you have equal amounts of salt and water in your urine. And when do you excrete salt and water in your urine? When the patient is taking diuretics. So if a patient is on diuretic, their salt and water may be almost the same. So that would cause isostinuria. Next was tubular transport. How are you finding glucose and sodium? Sodium this morning I did. So do you want to go over it again? Guys?
I'm sorry.
The next chapter is tubular transport. We discussed glucose, sodium, potassium, urea. So under the sodium I did this morning, right?
Right.
So do you want to go over it again?
If you have time, sure.
I mean, I have time, but I'm feeling somehow you're like getting saturated. It's like slowing down a bit. You're okay?
We're good.
You're good? Okay. If you need to just go and drink some water, put some water on your face, feel free to. Because I just want you to participate. Otherwise, no, like I'm not understanding if you're getting it or not. Okay, let's start with tubular transport. We discussed glucose first. So when we talk about glucose, the transporter on the apical surface is what?
SGLT.
And the basolateral surface will be predominantly GLUT2, by which glucose will enter. So all the complete reabsorption happens in the PCT. Therefore, maximum glucose should be present in the tubular fluid present in the Bowman's space. Because in the PCT, there will be complete reabsorption. Okay? So based on this, they found out that when the filtered load is 375 milligrams per minute, that's when the carriers get saturated. So if filtered load is 375, what plasma glucose does it correspond to? So filtered load is plasma glucose times GFR. 375 is plasma glucose. And how much is GFR?
125.
125. So when you solve this equation, ultimately you will get plasma glucose is 375 divided by 125, which is 3 milligrams per ml. You convert it into deciliter by times by 100, 300 milligrams per deciliter. So according to this theory, this is your plasma glucose and the x-axis, y-axis is filtered, reabsorbed or excreted. So according to textbooks, they told when filtered load is 375 milligrams per minute, so all the way up to this value, whatever was filtered had to get reabsorbed. So you had a single line for filtered and reabsorption because they were equal. And at this point, the plasma glucose it corresponded to was 300 milligrams per deciliter. But in reality, what happened? When your plasma glucose hit 200 milligrams per deciliter, that's when the carriers got saturated. So in reality, as soon as the plasma glucose reaches 200 milligrams per deciliter, at this point, when the filtered load is much below 375, so that's when your reabsorption will stop. So your reabsorption is only between A to B, filtered is reabsorbed, and once it hits point B, your reabsorption will deviate and stop earlier rather than going all the way up to 375. So the deviation which is happening earlier is called as splay. And after point B, your filtered load will continue. So beyond point B, filtered load will continue, and whatever is filtered ultimately gets excreted. So after a value of 200, the filtered load line will continue, reabsorption has stopped, and at this point you start a new curve here which is parallel to filtered load. So that indicates that once the carriers get saturated, whatever is filtered is getting excreted. So the splay is reabsorption stopping much earlier, deviating from the natural course much earlier. And the reason for the splay, you have already told me many times, is heterogeneity of nephrons. Cortical nephrons have shorter tubules and they have less carriers. So even though the expected value was 300, when the blood reaches 200 milligrams per deciliter, carrier proteins get saturated. So this value of 200 milligrams per deciliter, what do you call it as? Renal threshold. Good. So that's about glucose. Next, we did sodium. So the sites where the carriers are located, PCT, where maximum reabsorption happens, then the thick ascending loop of Henle, where 25% gets reabsorbed, early distal tubule, where about 5% gets reabsorbed, late distal tubule and collecting duct, remember it's only 3%, which is mainly on the carrier is only on the P cell, which is under the influence of aldosterone. So questions like maximum reabsorption happens in the PCT. Therefore, maximum sodium should be present in the tubular fluid present in the Bowman space. There it is 100%, and when it gets reabsorbed, it will start decreasing. So the maximum tubular fluid concentration of sodium is in the Bowman space. So let's enlarge PCT, and the predominant carrier protein in the PCT, SGLT, you remember that, right? So most of the carriers are symporters, which depend on the sodium potassium ATPase pump. And this pump depends on oxygen. Therefore, the site of maximum oxygen consumption is also the PCT. More and more of sodium gets reabsorbed, greater and greater will be the oxygen consumption. Majority are symporters. You only have one antiporter. And what's the antiporter?
Sodium hydrogen.
Sodium hydrogen.
Sodium hydrogen. Many of you forget the direction. Sodium reabsorption means sodium is entering, H plus is leaving. And this pump, I told you this morning also, is stimulated by angiotensin 2. So in a person with hypovolemia, what happens to angiotensin 2 levels? Increase. Therefore, sodium hydrogen pump works harder. Therefore, what will happen to the blood pH?
Decreases.
Sodium
Decreases.
choose one.
It will decrease.
Okay, because more and more of H plus is excreted.
The blood will have less hydrogen.
Less
But-
hydrogen, but what will happen to the pH?
Increases alkaline.
Correct. You were correct, but you told both, right? So I asked you to just tell me one.
Yeah, my bad.
Okay. Are you getting this? If angiotensin 2 increases, this pump activity will increase. So what's happening to H plus? It's leaving your blood. And if H plus is leaving, your blood H plus will decrease. And if the H plus decreases, what's happening to the pH? Alkaline. Okay? At least remember this for acid base. For now, you might not need this, but in acid base, I need this information. For now, just remember that angiotensin 2 can stimulate this pump. Now come to the thick ascending limb. What's the pump in the thick ascending?
Sodium, potassium, chloride.
Sodium, potassium 2 chloride, co-transporter. And give me the blocker. What's the loop diuretic?
The female, the furosemide and the ithrosonic acid.
Furosemide and ethacronic acid. And what's the most common complication of this drug?
Hypokalemia.
Hypokalemia. Now during this transport process, what happens? Some of the potassium can diffuse back. So as the sodium potassium chloride is going into the blood, some of the potassium can diffuse back into the lumen. So to balance the charge, what will happen to calcium and magnesium? They enter the blood. So if you block this pump, calcium magnesium absorption also may get affected. And a person who is on a loop diuretic can excrete how much extra sodium?
25%.
25%.
So 25% of sodium can get excreted. So that is good. That will help to elevate or reduce the blood pressure. Diuretics are used to reduce the blood volume. Early distal tubule, what's the pump?
Sodium chloride.
Sodium
Second.
chloride. Yes. Thick ascending is sodium potassium chloride 3. Early distal is only 2, sodium and chloride. Give me the blocker.
The him, hydrochlorothiazide, inedible, and metazole.
Good. Thiazide diuretics, hydrochlorothiazide, indapamide, metalozone. So they block this pump. And this drug also causes hypokalemia because 5% sodium chloride which should have got reabsorbed here does not. So you have an extra 5% sodium chloride reaching T cell. So your aldosterone tries to take in some, and in that process it will excrete potassium. So both the group of drugs cause hypokalemia. That's why you will need a third group. Before that, tell me the action of aldosterone on the P cell. Basically, aldosterone binds to receptor, and what's the channel it produces?
It increases the sodium reabsorption
By
and increases
synthesizing?
potassium secretion.
Correct. By synthesizing ENaC, it will take in sodium, during which the lumen will become negative, and that will be the driving force for excretion of potassium. So action of aldosterone is to reabsorb sodium and water and excrete potassium. Which are the drugs which are aldosterone antagonists? Name the drug.
Spironolactone.
Spironolactone, amiloride, triamterene. So because they block aldosterone, they won't reabsorb sodium. And if sodium is not reabsorbed, potassium won't be lost. So that's why they are called as potassium sparing diuretics. ANP. What does ANP do?
Inhibits sodium reabsorption.
By inhibiting ENaC. So ANP can inhibit ENaC. So that's why it acts as a natriuretic factor. Fill this up. Increased sodium intake, decreased sodium intake. Comment on ECF volume, blood pressure, renin-angiotensin system, angiotensin 2 levels, aldosterone levels, sodium reabsorption, sodium excretion, what happens. Also make a note of you can also make a note of ANP, peritubular capillary pressure, and then comment on sodium reabsorption and sodium excretion. This is a quicker way on the exams, right? So start with increased sodium intake. What happens to ECF volume?
Increase.
Sodium gets reabsorbed initially, so ECF volume increases, blood pressure increases, due to which your renin-angiotensin is not required. Angiotensin 2 and aldosterone will decrease. That will affect the sodium reabsorption in the PCT for angiotensin 2, aldosterone in the late distal tubule and collecting duct. Your ECF volume is high. Can ANP help?
No.
No.
No, to correct it.
Yes, it's a diuretic. No.
Correct. So can ANP help? Yes. So what will happen to ANP secretion? Increase. How does it actually happen? Because the venous return increases, it will stretch the atria. So the ANP release will increase. Because your ECF volume is increased, what will happen to the proteins? Dilute or concentrate?
Dilute.
Dilute. So what will happen to the oncotic pressure? Decreases. So the peritubular capillary oncotic pressure drops. Because of all these changes, your reabsorption will decrease, excretion will increase. And the opposite, decrease. Decreased intake, ECF volume will decrease, blood pressure will decrease. You need RAS to be activated. Angiotensin 2 and aldosterone will increase, which will act on PCT and the P cell. Your ECF volume is already less. Do you want ANP?
Yes.
Why?
No.
Your ECF volume is already less. ANP can make it worse. Do you want ANP?
Oh, I'm sorry. No. It doesn't work here. It inhibits.
It inhibits ANP release. What will happen to your proteins when your ECF volume is less? Proteins get concentrated. As a result of that, peritubular oncotic pressure will increase. And because of all the collective actions, sodium reabsorption will increase and excretion will decrease. Okay? Potassium, mainly we are concentrating on the regulatory sites. What are the two regulatory sites for potassium? In the late distal tubule collecting duct. For potassium, maximum reabsorption happens like all the others in the PCT, maximum reabsorption happens. The regulatory sites are P cells and I cells. P cell, who works on P cell? Aldosterone. What's the function of I cell? Acid-base regulation. So that should give you the clue of what we are discussing. So if the P cell is aldosterone dominant, what does it regulate? Sodium reabsorption and potassium excretion. Since you already have P cell regulating excretion, normally what does the I cell regulate? Potassium reabsorption, and it regulates acid base. So what's the other ion it carries? H plus. And this pump is the hydrogen potassium ATPase pump. So within physiological limits, this is the action of P cell and I cell. You know P cell is aldosterone excretion, therefore I cell favors reabsorption. But because the I cell can handle potassium and H plus, when you have a potassium disturbance or an H plus disturbance, then the I cell function, the pump can work both ways to correct the problem. So what are the potassium disturbances we spoke about? Hypokalemia and hyperkalemia. Hypokalemia, start from the problem. What happened to blood potassium level? Decreased. So what will that, this is only the I cell, okay? Only the I cell can compensate. So what will the I cell try to do? Get in potassium, but in that process what is excreted? H plus. So in order to correct hypokalemia, the I cell got rid of H plus. So what does that result in? Metabolic
Acidosis. Alkalosis.
metabolic alkalosis. In hyperkalemia, you had more blood potassium. So now what will the pump try to do? Get rid of potassium, but in that process what entered? H plus. So as a result of compensation of hyperkalemia, it can result in metabolic
Acidosis.
good acidosis. Next, what are the H plus disturbances? In metabolic acidosis, how will the I cell try to compensate? And metabolic alkalosis, how does the I cell try to compensate? So in metabolic acidosis, you have too much H plus in the blood. Therefore, what will the I cell try to do? Get rid of H plus. But in that process, the binding sites are diametrically opposite poles. So it has to go in opposite direction. So in the process of eliminating H plus, it gets in potassium. So what is the result of compensation of metabolic acidosis? Hyperkalemia. If I ask you any question on this, you start from the problem. So metabolic alkalosis, you had less H plus. So what will this pump try to do? Get in H plus, but in that process it's getting rid of potassium. So in an attempt to correct alkalosis, you lost potassium. So what will that give rise to? Hypokalemia. So that's with potassium. When it comes to urea, what happened to urea? Urea channels are located in the PCT. Then you have the thin ascending limb and inner medullary collecting duct. So maximum 50% reabsorption happens in the PCT. Rest of the urea just goes down. But when it goes up in the ascending limb, even though there's a channel, nothing happens because the fluid is dilute. And urea can't leave the dilute solution. But as urea travels further, the requirement for urea gradient is ADH. ADH will cause water reabsorption, which will concentrate urea, and by the time it comes to inner medullary collecting duct, its concentration is maximally reached, and that will keep the urea from the tubules into the interstitium, and you don't want it to get washed away when water comes out. So that's why it re-enters the thin ascending limb. So it moves from high to low and from high to low. So this way it gets recycled. So this is urea recycling. And the main reason why it should get recycled is to prevent the urea from getting washed away. And because of that, your medullary osmolarity at the medullary interstitium is as high as 1200 milliosmoles per liter, which is favorable osmolarity for most of your water to get reabsorbed. So which segment is urea leaving the tubules? In the inner medullary collecting duct. In which segment is re-entering the tubular fluid? In the thin ascending loop of Henry. So read the question carefully when we ask you about urea. And what's the requirement for this urea recycling? ADH. Why? Only if ADH reabsorbs water can urea get concentrated. So if you don't have ADH, remember the osmolarity was 100 here. So if the osmolarity remains 100, then it won't concentrate urea. Then what would have happened to urea also? It would get excreted. So what's the pre-requirement for urea gradient? ADH. So that's why ADH is the key regulator for the counter current mechanism. Based on that, we had the TFP ratio. Okay, there are three possibilities: equal to 1, greater than 1, lesser than 1. So if you look at it, majority of substance when they are filtered are isoosmotic, right? So their Bowman space and glomerular capillary concentration is equal. So in the beginning, for all the most of the substances, their glomerular capillary and Bowman space is equal. So the ratio is equal to 1. But in the PCT, that's where maximum reabsorption or secretion happened. So what will happen to the TFP ratio? It will change. For PAH, how much got filtered? 20%. And in the PCT, everything got secreted. So TFP ratio increases maximally in the PCT, and TFP ratio for PAH will be least where? Where is the TFP ratio for PAH least?
In the Bowman space.
In the Bowman space, because in the Bowman space there was only 20%. So the tubular fluid level was very less, it is least. But in the PCT it reaches maximum. Okay. So based on that, what is ratio equal to 1? Numerator is equal to denominator. That means the substance here and here are equal. That means it has to be isoosmotic reabsorption. Give me a substance which is isoosmotically reabsorbed.
Like sodium and those ions.
Sodium, predominantly sodium. If TFP ratio is greater than 1, what is greater? Where is it greater? Numerator or the denominator?
Numerator.
It's greater in the tubular fluid compared to plasma. So why was the substance greater in the tubular fluid? There are three possibilities. Either it is secreted, or it is not at all moving, but water continues to leave. So substance is not moving, that's inulin. Only water is leaving. Therefore, what will happen to inulin? As it goes lower and lower down, as water gets reabsorbed, it's getting more and more concentrated. Therefore, where will inulin concentration reach maximum? Where will be the TFP ratio for inulin maximum? Inulin does not move. What's responsible for concentrating inulin? Water reabsorption. So where do you think inulin will get maximally concentrated? The last part where water gets reabsorbed. So which segment does the last part of water get reabsorbed?
Collecting duct.
Collecting duct. Inner medullary collecting duct. Like urea, where did urea get maximally concentrated? Inner medullary collecting duct. Inulin also depends on water reabsorption. So where will inulin concentration reach maximum? In the last part where water was reabsorbed, that's inner medullary collecting duct. And what's the third possibility? The substance did get reabsorbed, but more water was reabsorbed compared to the substance. So which was the substance where more water got reabsorbed compared to the substance? Urea. So the three possibilities are substance is either secreted, or only water is getting reabsorbed, not the substance, that's inulin, or urea gets reabsorbed, but compared to urea there's more water moving along with it. So that way the urea gets concentrated in the tubular fluid. TFP ratio less than 1 means it's greater in the plasma compared to tubular fluid. So it has to be a substance which is reabsorbed in excess. So if a substance is reabsorbed in excess, its plasma concentration will be greater than tubular fluid. And which were the substances which are reabsorbed in excess? Glucose and bicarbonate. How will you differentiate? Glucose will get completely reabsorbed, so its tubular fluid concentration goes to 0 and the ratio becomes 0. And once you know this, we draw the graph. So in the graph, this is the PCT length, where you have the beginning of the capillary and end of capillary, and you have the TFP ratio 0, 1, 2, less than 1, greater than 1. If it is 1, that means the tubular fluid and plasma concentration are the same. It's isoosmotic. Give me the substance.
Sodium.
Good, sodium. The one which has the highest line should be the one which is maximally secreted. What is it?
pH.
pH. Then you have a line like this, and there's another line where there's a steady sharp increase, and as more and more water gets reabsorbed, it sort of steadies out. So which is this line here?
Urea.
Which depends on more water getting reabsorbed, urea. And which is the one which increases steadily throughout with every water reabsorption? It could be inulin, plus even creatinine line is close to that. So this line can indicate either inulin or creatinine. If the ratio is less than 1, there are two possibilities. One, the ratio goes to 0, which has to be
Glucose.
or the ratio will decrease sharply and then it's sort of steady phase. It will be maintained at that level. That should be bicarbonate. So that's the TFP ratios. So that is with respect to topic 3, solute handling. And then we went to counter current mechanism. I'll do ADH a little bit later. First, let's do the counter. If somebody wants to leave, please leave. Anyway, the session is getting recorded. Since you asked for it, I'm just continuing. So let's talk about the counter current mechanism of urine formation. Counter current because the fluid column is moving in two opposite directions and because of the selective permeability of loop of Henle. So what happens to the interstitium as you go to the cortex towards the outer and inner medulla? At the cortex, sodium was followed by equal amount of water. So the osmolarity to begin with was 300. But somewhere along this segment here, ascending, thick ascending, solutes went out, sodium, potassium and chloride. Water was not allowed to follow it. So along this segment, there was lots of sodium, potassium and chloride, but no water, due to which the osmolarity started increasing, 400, 600, so on. And by the time the fluid reached here, your ADH caused water reabsorption, due to which urea got concentrated, which created a gradient for urea, high concentration to low concentration. And in order to prevent it from getting washed away by water, it again moved from high to low and re-entered the tubular fluid and kept getting recycled, due to which the urea concentration was maintained, which increased the osmolarity further. So it reached a maximum of 12 to 1400, which is a favorable osmolarity, milliosmoles per liter. So your loop of Henle is responsible for multiplication of this gradient. So you call the loop of Henle as the counter current multiplier. Okay. Next, what happened? Fluid entered the Bowman space, which was isoosmotic. In the PCT also it was isoosmotic. But as the fluid descended down, it was exposed to a higher osmolarity outside, due to which water left towards 400. And as water left, inside became concentrated to match with outside. Now this 400 entered here. Outside has already become 600. So the water will move towards 600. So inside will get concentrated because water is leaving. So it matches with 600 outside. This 600 comes down. Outside is 800. So more water will leave. So inside becomes concentrated to match with outside. 800 comes here. More water leaves. So the inside gets concentrated to match with outside. As it goes up, water is not allowed to leave. So it starts getting diluted. So much so, by the time it leaves the thick ascending and enters the early distal tubule, its most hypotonic level. The osmolarity will be around 100. And as it comes lower down, if ADH is present, it causes water reabsorption. So the osmolarity will now again start increasing. And if maximum ADH is there, it will match with outside, 1200 milliosmoles per liter. Okay. What sees to it that the sodium chloride which is moving is not being washed away? That's the vasa recta. As the blood flows this way, it gives out sodium chloride from one limb and takes back the sodium chloride in the opposite limb. So it keeps recycling sodium chloride and conserving sodium chloride so that the gradient is maintained. So you call the vasa recta as the counter current exchanger. Okay. So this is pretty much how our urine is getting concentrated thanks to ADH, which keeps our urine output at 1.5 to 2 liters per day. For any reason, if you don't have ADH, the urine continues to be dilute. Urea fails to get concentrated, urine continues to be dilute. And if urine continues to be dilute, we will excrete large volumes of urine. And what is excretion of large volume of urine called as? Polyuria. And what were the two ADH abnormalities where ADH does not work? What were the two different abnormalities? They are collectively called diabetes insipidus. And what are the two types? Let me just erase this line. Did you understand the countercurrent mechanism?
Yes.
Okay. So now let's talk about a patient presenting with polyuria. What are the different possibilities? One is diabetes insipidus. What's the other possibility?
Okay.
Diabetes
Right.
mellitus. Where else? Which drugs you get polyuria?
Diuretic.
Diuretics. Good. Any other drug we mentioned this morning?
Lithium bicarbonate.
Lithium bicarbonate, used to treat bipolar disease. So all these will complain of polyuria. So what's the differential? How will you differentiate? In diabetes insipidus, the urine contains only water. And what will be the osmolarity? It entered at 100, right? So the urine osmolarity will be somewhere around 100 milliosmoles per liter. In mellitus, why is there polyuria? Because the glucose is dragging water. So urine contains glucose. Therefore, urine osmolarity will be slightly more than this. It is polyuria. Polyuria means the urine is sort of dilute. So the osmolarity has to be less than 300. But say it is around 200 to 250 milliosmoles per liter. Why? Because of presence of glucose. Diuretics, there's equal amount of sodium and water in the urine. So there could be isostenuria. And if you find sodium in the urine, that will tell you that it is diuretic, if sodium is present, right? Lithium carbonate urine contains what? What did lithium carbonate do? It prevented aquaporin. So which insipidus did it give rise to? Nephrogenic. That means the urine contains only water. So what osmolarity the urine will be at? Around 100 milliosmoles per liter. Does this make sense?
Yes.
Okay, so these are the different causes for polyuria I meant to say. Next, if ADH is less, patient has polyuria, that tells you that there is a problem with secretion of ADH. So where is the problem? Either in the hypothalamus, supraoptic nucleus, or posterior pituitary. And because it's a neurogenic central cause, what do you call it as? Neurogenic diabetes insipidus. If ADH is high and patient still has polyuria, that means this ADH is not working. So why is it not working? The hormone is there. Then why else is the hormone not working? There can be problem with the receptor or aquaporin in the kidney. So what will you call this as? Nephrogenic diabetes insipidus. And the drug which causes nephrogenic would be lithium carbonate, used to treat bipolar disease. What's the differential diagnosis for high ADH? Which other disease the ADH is going to be high? Syndrome of inappropriate ADH. But what's the difference between nephrogenic and inappropriate? Here ADH is high and it is working, right? In nephrogenic it's not working, so they have polyuria. In SIADH it is working, So what will they have? Oliguria. They have less urine. Okay. So the difference between neurogenic and nephrogenic, neurogenic ADH is less with polyuria. Nephrogenic ADH is high, despite which they have polyuria. And SIADH, ADH is high, but what happened to their urine? It's really concentrated, oliguria. Did you get this?
Yeah.
Am I confusing you?
No, it's helping.
You okay? Yeah. I mean, that's how exams are, right? So that's why this is a session where you're preparing for your exams. If you want any clarification, please ask. We're almost done. So that's about the diseases of ADH. Now let's make that last table where I'll give you the condition. I went through a bit quick that time, and some of you had questions. And comment on ADH levels, comment on plasma volume and plasma osmolarity. Volume and osmolarity are always inverse. They cannot be in the same direction. Comment on urine volume, urine osmolarity, and then comment on free water clearance. I want you to tell whether free water clearance is positive or negative. Let's start with neurogenic diabetes insipidus. Lesion with the hypothalamic supraoptic or posterior pituitary lesion. What happens to ADH secretion?
Increases.
I may decrease, right?
Yeah.
Where else can ADH decrease? What intoxication?
Alcohol.
Alcohol intoxication can also cause the same effect like neurogenic, where ADH will get suppressed. Start from what happened first. ADH was suppressed, due to which water was reabsorbed or excreted.
Excreted.
So your urine volume increased. And if the volume is increasing, what should happen to the osmolarity? Urine is diluted. Decrease. If you're losing water in the urine, what's happening to water in your body?
Decrease.
Your plasma volume will decrease. And what will happen to the plasma osmolarity? They're always inverse.
Increases.
It's like you're losing water from one end. That means your body water has to be in the other direction. If you're losing water in the urine, your plasma volume has to decrease and get concentrated. And what will happen to free water clearance? You're losing water, right? So free water clearance will be positive. Nephrogenic. And what is one cause for nephrogenic? Lithium carbonate, used to treat bipolar, can induce nephrogenic. There is a problem with kidney, due to which your ADH cannot work, due to which your water cannot get reabsorbed and it starts getting excreted. Therefore, what will happen to your urine volume?
It'll decrease.
No, ADH cannot work.
Increase.
Increase, and osmolarity will decrease.
Decrease.
You're losing water in the urine. So what will happen to your body water?
Decrease.
What will happen to your plasma volume?
Decrease. Decrease.
If you're losing water in the urine, what happens to your plasma volume?
Decrease. It decreases.
Decreases, and your plasma is getting concentrated. And what will happen to the free water clearance again? Positive.
It's positive.
And because you're losing so much water, and because your plasma volume is decreasing, osmolarity is increasing, it will act as a continuous stimulus. And what will happen to ADH secretion in this person is high, despite which it cannot act. Because there is a problem with receptor or aquaporins, despite ADH being high, it cannot work. So it causes tissue resistance. SIADH, you have a tumor which is secreting too much ADH, which is acting. There's an overproduction of ADH and hypersecretion of ADH. It can be tumor of posterior pituitary hypothalamus or carcinoma of the lungs, foot cell, due to which water is getting reabsorbed or excreted.
Reabsorbed.
Reabsorbed. So what will happen to your plasma volume?
Increasing.
And osmolarity will decrease.
Decreases.
Because you're reabsorbing water, what will happen to your urine output?
Decrease.
Less.
And decrease.
And osmolarity. Less output means urine is, just imagine when you pass less urine, it's really dark yellow. That means what happened to osmolarity? Increased. And what will happen to free water clearance?
Negative.
Negative. Are you okay with these three?
Yeah.
Yes.
Okay, next, what happens in psychogenic polydipsia, otherwise called as water intoxication? You're drinking too much water. Here, ADH is not the first problem. Problem is you're drinking too much water. Where is it going?
Plasma.
In the plasma. So plasma volume will increase, which will dilute your plasma. Osmolarity will decrease. Now, because of this change, what will happen to your ADH secretion?
Decrease.
Decrease.
Decreases. And following this, what will happen to your urine? Just imagine you drank 10 glasses of water. What will happen to your urine?
It increases. Output increases.
And osmolarity will decrease. Free water clearance will be positive. Now here, plasma and urine look similar. They can never be the same. But why is it looking similar? We started from the cause, what happened first, and the urine is showing you only the effect. And following this urine, if I again ask you what happens to plasma volume and osmolarity, it should be in the opposite direction. But it's too confusing here, so I'm not asking you again what will happen to plasma. So I want you to start with, when you drink water, what happens to your plasma. As a result of that, what happens to ADH. And following this, we are commenting only what happens to urine. Okay, so they are not the same. They are starting from the cause to the final effect only on the urine. And again, if I ask you what happens to plasma, it will be the opposite of your urine. Last one, water deprivation, dehydration. So if you don't drink water and continue to sweat, ADH is not the problem here. What happens first?
Decrease. In
Decrease
plasma.
in plasma
Your
volume.
plasma
Plasma
volume will
volume
decrease,
increases.
osmolarity will increase, which will stimulate your ADH secretion. And following ADH secretion, your water will try to conserve. So what will happen to your urine? It really gets concentrated. Urine volume will decrease, osmolarity will increase. And following this, if I ask you what will happen to the plasma, it will be opposite. Okay? And what is happening? Urine is really concentrated, so your free water clearance is negative. Did you get this?
Yes.
Yes, you can't memorize this. You have to use your logic. So if you're reabsorbing water means you're excreting less. If you're excreting more water means your plasma is becoming less. So they're always like opposite. Okay? For micturition, what sympathetic system? Remember the tiger, you don't want to pee. So what does the sympathetic hypogastric stimulation do?
Stimulates the bladder to fill and prevents you from peeing, pretty much.
It prevents you from peeing, right? So what does it do to the detrusor?
Relax the muscle.
It will relax the detrusor muscle. It keeps the internal urethral sphincter closed. And external sphincter, of course, is not under sympathetic. It's under the pudendal influence. It's already closed. Once the bladder is stretched, as the urine starts filling, your bladder gets stretched. That will activate the mechanoreceptors, which will activate your pelvic nerves. That's the parasympathetic. And what does the parasympathetic do? It leads to contraction of the detrusor, and it will relax the internal. But if conditions are not favorable, your external is still closed by the pudendal nerve. And once conditions are favorable, your pons will stop sending signals to the pudendal nerve. And following that, what will happen to the external? It will also open. So for micturition to happen, your detrusor should be contracting. Both your internal and external urethral sphincters should relax. And only then there's voiding of urine. So based on this, they did a study where they filled the bladder in 50 ml increments. First they emptied the bladder using a catheter and filled it in 50 ml increments. And they recorded the intravesicular volume in x-axis and the intravesicular pressure within the bladder. They found that when they gave that first 50 ml injection of fluid, there was a slight increase in pressure because it stimulated some mechanoreceptors and there was a few initial contractions which disappeared. But between 50 to what volume it remained unchanged, the pressure? How much ml? Anyone? Guys?
No.
Between 50 to how much 100? 400 ml. So this 400 ml you have to remember. So up to 400 ml after that, the pressure remained constant. Why? According to Laplace law. As you stretch the bladder, the radius increased, and as the radius increased, the tension also increased proportionately. They cancelled each other and the pressure remained constant. But after 400 ml, lots of mechanoreceptors got stimulated, and that stimulated your parasympathetic, and the micturition reflex was stimulated. After which the detrusor will contract vigorously. So what happened to the pressure? It will increase significantly. So you have 1A, this is called as the cystometrogram, the graph. So first 50 ml there was a slight increase, 1A. In 1B the pressure remained constant due to Laplace law, both increasing proportionately. And in the segment 2, the micturition reflex was initiated and there was a sharp increase in pressure, and that happened because of detrusor, powerful detrusor contractions. I think I've pretty much covered everything and hope we did some justice to the review. Okay? Anything else?
Thank you so much, Dr. Praja.
That was an amazing
Was it
review.
helpful? Yeah. Yes, we covered most of it. Yeah, in between I felt you were a bit tired, so that's the reason I was asking you. But otherwise, I'm glad I finished the review. Anyway, it's recorded, so you can just go back and listen to it. Okay?
I want to ask Dr. Praja, for the first 2 lectures for cardio,
Yes.
are we gonna have like questions from there?
From this block, only one lecture was done, right, for cardio?
Yeah.
Okay, so you'll have questions from that, and from the previous block also you will have, but the ratio is 80-20%. So 20% is 6 questions from old block, and rest of the questions from current block.
I see. Okay.
And
Sounds
from
good.
current block, obviously cardio is only one topic, you'll have less. More of it would be hematology and renal.
Okay. Sounds
Okay?
good.
Yeah. Okay, guys, have a good evening. Thank you.
You too.
Thank
And
you,
all the
Dr.
best.
Praja.
Yeah, all the best for the exam. Bye.
You can.